Okay, so thank you very much. I have to admit that it wasn't planned, but the last question regarding adverse effects is extremely relevant, and I fully agree with the last point made. One of the things that, in my opinion, will help promote the medicinal use of cannabis the most is actually having the industry recognize, indicate, and talk about the adverse effect. As someone who lives on the verge between the industry and policymakers want to hear that. And once they hear that the industry itself recognizes and addresses the adverse effects, I imagine that everything will be a lot easier. So just a short story. I'm loving South Africa. I'm only here for 5 days. One of the things I did in advance is I booked a hike up Table Mountain. And I got this great tour guide called Rian, which is probably an Afrikaans name because it's spelled with 2 A's. And while we're climbing, kind of rock scrambling, he asked me, so what are you doing in South Africa? I'm here for a conference. What's the conference about? It's about cannabis. Cannabis, awesome. What do you do for a living? Well, I'm an addiction psychiatrist. So what are you going to be talking about in the conference? I'm going to be talking about cannabis addiction. So then Rian stops kind of mid-air because we're rock scrambling, and he says, you're going to a cannabis conference, and you're going to be talking about cannabis addiction. Are you brave or dumb? So to be honest, I'm neither. But I am in quite a unique position to talk about the topic. A, because it's one of my major focuses of research, and anyone who conducts research knows that when you do research on a topic, you live it. You read immensely. You talk about everyone who deals with the same topic worldwide. So this is not just anecdotal evidence. The second thing is that, on the one hand, I had the only addiction treatment service in the public sector in Israel which prescribes medicinal cannabis as part of addiction treatment. So I prescribe it to individuals with chronic pain. I prescribe it to individuals with PTSD. I prescribe it to individuals with opioid addiction. And on the other hand, I have quite a lot of individuals knocking on the door of the clinic saying, listen, I've been using too much weed. I think I'm addicted. My life is spiraling out of control, and I'd like treatment for cannabis addiction. Now, just to note, we're not talking about the industry or the society saying you've been a bad boy or you've been a bad girl for smoking pot. We're talking about individuals that come to our treatment centers seeking treatment for cannabis dependence. 1 out of every 5 individuals that arrive at our treatment centers seeks treatment for cannabis addiction. First, by the way, and second are alcohol and opioids. Third is cannabis. So I'm in a kind of unique position. On one hand, I prescribe cannabis, and on the second hand, I wean people off cannabis. It turns out that our service in Israel is not unique, nor is it extraordinary. If you look at the number of treatment admissions to addiction services in Europe, the primary substance is always alcohol, but in Europe, the secondary substance is usually cannabis. Sorry, not the secondary substance, but the second most common primary substance for individuals seeking treatment for addiction is cannabis. In the US, you can see here on the right, the number of admissions to addiction treatment centers where cannabis is the primary substance of abuse is slowly increasing. It's still number 3, by the way, after opioids and after alcohol. But in 2015, 13% of US admissions to addiction treatment centers had cannabis listed as the primary substance of abuse. Now this is where it becomes a bit tricky. On the one hand, cannabis is by far less addictive than a lot of other substances. 9% of lifetime users of cannabis develop addiction, 15% of lifetime cocaine users, 24% of lifetime heroin users. But because so many people use cannabis, even though it's relatively not a very addictive substance, at the end of the day, you have quite a lot of individuals who suffer from cannabis addiction. Now, I've been using the word addiction, but the truth is that in the addiction scene, we have quite the Tower of Babel in terms of the language we use to describe addiction. So we can talk about addiction or dependence, or use, misuse, abuse, problematic use disorder. They're not synonyms, but just for the sake of today's talk, I'm going to be using them interchangeably. So first of all, let's talk about what is addiction. So lucky for us, we don't have to invent the wheel. The WHO, the World Health Organization, has done it for us in a codex, in a book called the ICD, the International Classification of Diseases. Every medical disorder you've ever heard about, every medical disorder you can imagine, appears in the ICD. ear infection, breast cancer, gout, rheumatoid arthritis, ADHD, social anxiety, depression, and yep, also addiction. So how is addiction defined according to the World Health Organization? It affects 3 central domains. One is the physiological domain. As time goes on, an individual develops tolerance, which means that he or she needs increasing doses to reach the same effect. Or if he or she stops abruptly, they'll suffer from withdrawal symptoms. So that's the physiological aspect. Then we have the psychological aspect, which is a compulsive preoccupation with a substance itself. And finally, we have the behavioral aspect, which is continuous use despite negative consequences. So just like everything else, you need X criteria out of Y. Here's 3 criteria out of 6. And that is the formal, global, international definition of addiction. It's true that in the States we use the DSM. We're talking about a codex which is a bit different. But for today's conversation, suffice it to say that those are the 3 domains that define addiction, regardless of the substance itself. So it doesn't matter if we're talking about alcohol addiction, tobacco addiction, stimulant addiction, opioid addiction, or cannabis addiction, the criteria are exactly the same criteria. So while it's true that cannabis addiction by and large is less severe, and that's why the mean length of cannabis use for people entering treatment is about 10 years, because you can generally live when you're addicted to cannabis. And that's where it's less severe than alcohol, cocaine, opioids, etc. But at the end of the day, most people come in looking for treatment after a specific life event. First kid is born, they hate waking up in the middle of the night when they're still groggy or a bit stoned. They get a new job, and they wake up not so good in the morning, loss of productivity, the boss gets mad. The new girlfriend, she's not happy with the weed, she wants him to kick him out, etc. So a lot of times, people enter treatment for cannabis addiction after a specific life event. Makes it hard for them to carry on their cannabis use. Sometimes, and the speaker before me spoke about money, it's a financial consideration. An individual saying, I'm spending $100, $1,000, $1,500 per month, I don't have the money anymore. But what's common to all the addictive substances, be it tobacco, be it alcohol, be it stimulants, be it opioids, or be it cannabis, is that they all cause an excretion of the neurotransmitter dopamine in the reward system. I'll decipher what I said just now. Dopamine is the pleasure neurotransmitter, and it's excreted in what we call the reward system in the brain. The reward system is a deep brain structure designed basically from an evolutionary standpoint to indicate that we've done something good, either as individuals or as a species for our evolutionary process. Basically speaking, the system is designed for us to do 2 things. One is keep on eating, and when we eat, dopamine excretion is increased by about 50%, so that's 1.5-fold. And the second thing we need as a species is to procreate. That's why when we have sex, dopamine excretion in the reward system of the brain increases 2-fold. So just from a neurobiological perspective, most of us should prefer sex over food, and most of us do, because we're getting the best out of our buck. We're getting more dopamine in the reward system when we have sex than when we eat. So what do addictive substances do? Addictive substances hijack that system and cause a substantially higher increase in dopamine excretion. Amphetamines increase dopamine 11-fold, by 1,000%. Cocaine increases dopamine by 300%, 4-fold. Nicotine and alcohol increase dopamine release in the reward system. All substances of abuse, all addictive substances, increase dopamine release in the reward system, including cannabis. THC increases dopamine release in the reward system a lot less than a lot of other substances we saw, but nevertheless it does. So this is the kind of conversation we're going to be having today. On the one hand, a lot less than other substances. On the other hand, but it still does. So maybe the addiction is less severe, but it still exists. So THC increases dopamine excretion in the reward system by about 1.5-fold. And that's why generally, even when you ask professionals, and this is the word by David Nutt said a few years ago, even if you ask professionals, well, how harmful is cannabis compared to other substances, they will say, for the most part, that it is relatively less harmful than a lot of other substances. But less harmful does not mean not harmful at all. And for policymakers, this is a major concern. So I just picked this off the Washington Post, And I think it says something extremely important. In order to promote the field, in order to promote medicinal use of cannabis, the industry itself should start talking about the adverse effects. Once it starts talking about the adverse effects, it'll open up a lot of ears to talk about the beneficial effects. So that's what we're going to be doing the 10 minutes that we have left. So first of all, how many people suffer from cannabis addiction? Generally speaking, and this data is over 10 years old, but it's still valid, out of all the people that ever use cannabis, so we call them lifetime users, 9% develop addiction. Of daily users, 50% develop addiction. And now, I'm already going to point out where the problem lies. Almost all the data we have is based on recreational users. How much can you copy-paste data from recreational users to medicinal users? That's a big question. As we'll see in about 5 minutes, not much. And we know that from other fields. For example, if you take methylphenidate, Ritalin, if people buy Ritalin off the street, then the chances of them becoming addicted are extremely higher than if they receive it as a prescription drug. So the same substance, if you get it as a prescription, your chances of developing addiction, the addiction liability, is substantially lower. So that's going to be a point that we're going to have to work on. The fact that we're taking data based on recreational use and trying to apply it to medicinal use, which is probably a problem. But nevertheless, if we're talking about recreational users, 9% out of lifetime users, 50% out of daily users develop addiction. And the problem is that those who develop addiction, generally speaking, are young men. And this is a great work by Louisa Degenhardt in a series of studies on the global burden of disease associated with substance use, showing that both men and women use cannabis and develop cannabis addiction. But men develop cannabis addiction a lot more. And when do they develop cannabis addiction? Usually between the ages of 16, 17, and 40. Those are the ages that society expects us to be productive. And that's why cannabis is associated with what the World Health Organization calls disability. Because men aged 16, 17 to 40 have an increased risk of cannabis addiction, and because they are supposed to be a productive part of society, WHO indicates that this costs society quite a lot of money. Disability-adjusted life years is the WHO's measure of disability. So you have cannabis addiction, 9% of lifetime users, 50% of daily users. Generally, young men develop it. Generally, that's the cause of disability. But same report shows that if you want to see how much cannabis dependence contributes to the global burden of disease, then first of all, a lot less than other substances. So tobacco is totally out of here. Tobacco is by far the #1 killer. It's off the charts, it's out of here. Among all other substances associated with what we call an increased global burden of disease, alcohol is responsible for 50% of the global burden of disease associated with substance use. Opioids are responsible for 24%. Cannabis, even though it's extremely prevalent, is responsible for a mere 5.5% of the global burden of disease associated with substance use. So again, on the one hand, is it addictive? Yeah, increases dopamine in the reward system. How many develop addiction? Again, we're basing it on recreational users, but anywhere between 9% to 50%, which is a huge range. It does cause disability, but relative to the prevalence of use, the disability is generally relatively low, 5.5%, even though it's one of the most common substances used worldwide. Now, I mentioned that we have a real problem that we try to use data based on recreational use and copy it to medicinal use. Even the diagnosis itself should probably slightly change. And we're working on a project now with the University of Haifa in which we're trying to establish validated tools to diagnose cannabis addiction among those using medicinal cannabis. The same was done, by the way, for opioids. Because if you try to use the regular WHO or DSM to diagnose opioid addiction among those receiving prescription opioids, you're going to miss out on a lot of questions. So this is a measure, it's called the COM, the Current Opioid Misuse Measure, which asks questions which are very specific to medicinal prescription. For example, did you run out of your script? For example, did you double doctor? For example, did you run out of your script and have to take cannabis off a friend? So we probably have to establish new tools to diagnose cannabis addiction in individuals receiving medicinal cannabis through a doctor. The second most important issue I want to discuss today is that it's easy to talk about cannabis addiction, easy to talk about detrimental effects, but the more important thing is to ask ourselves, well, how is that compared to the alternative? And I want to talk about chronic pain, which is probably the most common diagnosis for which medicinal cannabis is prescribed worldwide. I'm not basing that on data, but I assume it is. Generally speaking, the bad news is that a lot of us are going to be suffering from chronic pain. The prevalence of chronic pain in Western societies, this comes out of the UK, is about 40% lifetime prevalence. 40% of us, 4 out of every 10 individuals is going to suffer from chronic pain. 14% of us, I'm one of them, is going to be suffering from moderate to severe chronic pain. And obviously, once we suffer from chronic pain, most of us are going to develop anxiety and depression. We're going to develop anxiety because we're going to be living with chronic pain, asking, am I going to be able to provide? Am I ever going to enjoy life again? Is my wife going to want to be with me if I'm such a non-productive person? And then depression seeks in. Obviously, once anxiety and depression seek in, we are in a vicious cycle. The more anxiety, the more restlessness, the more depression, the less we're engaged in enjoyable activities, and the more pain we experience. Now, there are medications to treat chronic pain. And for most countries, opioids are still the first line of medications. Now, opioids are quite amazing because they are effective both for short-term pain relief post-operative and end-of-life malignant cancer, irretractable disease. The problem is that it's been starting to be used more and more for chronic pain, and opioids have kind of a scary side effect. They can kill you. Now, it's true that we're all going to encounter death sometimes, but honestly, it's best to postpone it as much as you can. So that's one big adverse effects of opioid, but it's not the only adverse effects. There are a lot of adverse effects, gastrointestinal, neurologic, psychiatric, etc. Meaning that even though opioids are prescribed a lot for chronic pain, A, they kill, B, they can't kill, B, they have a lot of additional side effects, and C, they're extremely addictive because heroin, opioids in general, excrete dopamine in the nucleus accumbens, in the reward system of the brain, definitely higher than THC. So when we ask ourselves, well, cannabis is addictive, should we refrain from using it? The question should be, what is the alternative? And this is a study we conducted on 888 chronic pain patients. It sounds like a diabolical number, but it's not. 888 patients treated in the 2 largest pain centers in Israel. And we looked at those receiving prescription opioids for their chronic pain and those receiving medical marijuana for their chronic pain. What we tried to see is how many of them develop addiction, how are they doing in terms of pain, in terms of anxiety, and in terms of depression. And what we saw, first of all, the light gray are those receiving prescription opioids. About 17% of them developed opioid addiction. And just to remind you, opioid addiction is both lethal and has enormous side effects. 10.8% did develop, by the way, cannabis addiction, which is substantially less severe, nevertheless existent. So almost 11% developed cannabis addiction. But how are they doing? So when we compared their levels of anxiety and levels of depression, what we found is that individuals receiving medicinal cannabis for their chronic pain had substantially less depression and substantially less anxiety. And the interesting thing is that compared to individuals who received only opioids, that was clear. But some individuals received both medicinal marijuana and opioids, and they were doing better than those who only received the opioids, almost indicating that cannabis may have an attenuating effect on the negative side effects of opioids. But generally speaking, was cannabis addictive in our study? Yes, it was. But it's a less severe addiction, and especially when you compare it to the alternative. If the alternative are opioids, they are more addictive, more detrimental, higher adverse effects of anxiety and of depression. It's particularly true for moderate to severe anxiety depression, which is most detrimental. Generally speaking, cannabinoids, medicinal cannabis, can play an important role in the opioid epidemic on 2 levels. The first level is a public societal level. What we see, and I have to say this is a bit controversial because there are also other research reports coming out, but generally speaking, places that have legalized medical marijuana see less detrimental effects of the opioid epidemic, generally speaking. There are a few exceptions. And the second more important thing, this just came out in the American Journal of Psychiatry, is that some cannabinoids, for example CBD, has been starting to be used as a treatment for opioid addiction. So A, is it addictive, cannabis? Well, potentially yes, but B, can it be better than the alternative? And can we maybe even use it as a medicinal product? Yes, we can. So I have a red sign saying my time's up. I'm going to take 2 more minutes. The first is to say that we conducted another study to ask ourselves, okay, so some people develop cannabis addiction. What happens with them 1, 2, 3 years later? So this is a 3-year follow-up on almost 450 individuals with cannabis dependence. What happens to them 3 years later? By and large, for the majority of individuals, it was a self-resolving condition. So 3 years later, only 34% still fulfill the cannabis addiction criteria. None of them, by the way, received treatment. Some of them became total abstainers. Some of them became occasional users, but 35% just about remained diagnosed with cannabis addiction. So even if you follow up naturalistically, the majority of individuals will probably self-resolve. Those who don't self-resolve, there are very effective treatments. A, we should always address tobacco addiction. A lot of individuals who roll tobacco in their joints actually have tobacco addiction, not necessarily cannabis addiction. There are appropriate psychological interventions, motivational interviewing, CBT, and obviously appropriate rehabilitation and social. So, bottom line, is cannabis addictive? Is there even such a thing as cannabis addiction? The answer is yes, and it should be recognized as an adverse effect. It is substantially less detrimental than opioid addiction. We should probably do some kind of preliminary screening and follow-up to see which one of our clients is developing cannabis addiction. It doesn't necessarily mean they have to stop it. It doesn't necessarily mean that they should be minded and that we should follow it up and maybe look for less detrimental ways to treat the individual. And if we do encounter, we should refer to treatment because treatment is effective. And now maybe the last part. I actually have 3 motivations in being here, standing on the stage. First is I really wanted to see South Africa, and it's been great. The second is I've decided to dedicate my life to addiction, so I try to convey knowledge wherever I can. The third is that I actually need your help. I am not going to be developing any kind of therapeutic module. I'm not going to be developing a drug. That is probably your role. What we do know, though, is that when we want to treat addiction, and I'm finishing and wrapping up, when we want to treat addiction from a purely biological standpoint, what we would actually like more than anything is to find a compound that activates the receptor, but not too strongly, so it's a partial activator, a partial agonist, and that it dissociates from the receptor relatively slowly. The stronger a substance is, and the more rapidly it dissociates from the receptor, the more addictive it is. So addictive substances usually look like this. Whereas effective treatments for addiction usually look like this. And that's what we're looking for. We have 2 great examples from tobacco dependence in Chantix, it's exactly how Chantix works, and opioid addiction in Suboxone, it's exactly how Suboxone used. So anyone out there, if we could find a compound that will activate the receptor to a lesser degree, stay connected more, and dissociate slowly, we may be on the way to developing a cannabinoid-based medication for addictions in general and cannabis addiction in particular. Thanks a lot for listening.